Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. This patient had a dislocated Symfony IOL, and so I would perform IOL exchange. So I'll be performing my modified Yamani technique, and this time I'm going to be using the 25 gauge needle-guided externalization of the leading haptic, and I'll be using the CT Lucia 602 lens. The beauty of this technique, it's very gentle and atraumatic to the haptics, and even without using the CT Lucia, if you use it on a different lens like a sensor, it can work quite well. So this is a patient at the slit lamp. You can see the lens is jiggling around as the patient's blinking. You can see most of the optic is outside of the pupil. The patient received dilating drops, but clearly the patient's eye is not dilating very well. This is pretty typical in patients who have zonulopathy. You can see the haptic is essentially within the center of the pupil, and the lens is severely dislocated. So this is a patient in the OR now. I'm going to go ahead and make my mark for my trocar. I'm going to indent the sclera, and that posterior mark is 4 millimeters posterior to the limbus. I'm going to rotate the eye downward, and about 2.5 to 3 millimeters next to it, I'm going to make a sclerotomy, a tunneled sclerotomy, tunnel, 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 and then I rotate 90 degrees and enter perpendicular to the eye. So this is a cool confirmation. When you pull the needle out, if the trocar is sitting slightly tilted, that means you have a nice scleral tunnel, and this is more likely going to lead to a self-sealing incision when you pull the trocar out at the end of the case. I'm going to make some limbal marks for my Yamani, and I'm using the cannula to find 180 degrees apart. Set the caliper to 2.5 millimeters posterior to the limbus and make that indentation mark radial to that first one. And then using the cannula, an inked cannula, I'm able to mark 2.5 millimeters and then 2 millimeters adjacent. Do the same thing on the other side using the caliper, again in radial fashion, making my scleral indentation. So these are my paracentesis incisions. I'm making incisions for my externalization of the leading haptic, as well as incisions to place iris retractors because this iris is quite small, as well as for my 20 gauge Lewicki AC maintainer, and also my incisions so that I can do the IOL exchange, lifting the lens up. So I'm placing the iris hooks now, and you can do this as a two-handed technique. You want to make sure that the stoppers pull back, and then you can twirl the stopper so that the hook is facing down, and then you can cinch the stopper down. So this is a very, very efficient way of placing iris hooks. It shouldn't really be that difficult. So I'm injecting some dispersive viscoelastic to coat the cornea, and then this is my 3 millimeter diamond blade incision, and that's going to be the incision for the lens exchange as well as placing the lens for the Yamani. So through the trocar, this is the viscoat cannula. I'm pushing viscoelastic and then lifting the lens up, grabbing the lens with forceps. I cut the lens. And as I'm pulling the lens out, I'm using the other forceps in my right hand to protect the cornea, pulling the second half of that lens down so it goes down into the vitreous space and away from the cornea. As I pull, I'm able to deliver the first half out of the eye. And again, because there's no bag, the second half is able to just rotate back up. In order to get to that submarines ring, I place a 20 gauge Lewicki AC maintainer first, activate irrigation, and through the infusion, I'm able to burp that submarines ring out. This is intracameral Kenalog pulsing with the cannula, And then through the limbal incision, I'm doing a vitrectomy, making sure that there's no canalog in the anterior chamber. And then I go through the trocar and I do a limited anterior vitrectomy. This is 6x speed, and I just want to reiterate that you have to do a thorough vitrectomy, especially in the anterior chamber, making sure there's no vitreous to your wounds, but also you want to make sure that the vitreous is cleaned up right where you're going to be placing your needles. So on the left side and then the right side, you want to make sure that you do a good vitrectomy there, making sure there's no vitreous strands. When you put the lens and then you put the needles in the eye and so forth, and you make the scleral placement, you got to really make sure that you have no vitreous entangled in that area. Pushing some more dispersive viscoelastic. This is the right needle, bending the needle 9 millimeters from the tip, and then the left needle is at the hub, and I want to make sure that the bevel faces the approach of the haptic. This is a 25 gauge externalization technique. I'm placing the needle facing the bevel to the right. As the lens is delivered, the haptic is docked on the bevel of that needle. My assistant is delivering the optic, and as she does this, I'm able to pull out that 25 gauge needle, and the haptic goes out through that incision very nicely and atraumatically. I take over and deliver the optic and then the trailing haptic, making sure it's swept to the right. Protect the corneal endothelium by pushing some more dispersive viscoelastic. And this is the needle technique. I'm holding the trocar with the forceps, tunneling 2 millimeters, and then diving straight down. You want to stay in that same line. You tunnel 2 millimeters, dive down in that same line, puncture through the sclera, make sure you clear the ciliary body, and then you rotate. With microforceps, I carefully place that trailing haptic in the eye, and I'm able to dock the haptic on the bevel of the needle, and very easily I'm able to pass that haptic through the needle, disengage the syringe from the needle, making sure the needle goes down without any excessive turning. Grasping the incision with forceps, tunneling 2 millimeters, holding the eye in the neutral position, tunneling 2 millimeters. When you get to 2 millimeters, you dive down, make sure you clear the ciliary body, and then you rotate the needle into view. You don't want to rotate too prematurely because then you might hit the ciliary body and cause a hemorrhage. So you can see the needle bevel is facing towards the haptic. On the right side, that's towards me. On the left side needle, that's away from me. I flatten the haptic on the bevel, make sure it's flattened out. Once it's flattened, I'm able to cannulate it. It's just such an easy maneuver when you do it this way. With the CT Lucia, they do tend to slide out compared to the Sensar, and so I'm going to do a sequential externalization of the haptic. As I'm pulling the needle out, I'm grabbing the haptic and making sure not too much of the haptic comes out, because then that causes undue tension on the other side. Go ahead and cauterize the tip, which creates a small bulb. And then I go ahead and start withdrawing the needle on the right side. Again, you want to pull it in the direction that it was passed through the scleral tunnel, grasping the haptic with the forceps, and then cauterizing the tip. Whether you use high temp or low temp, it doesn't really matter. You just have to make sure you have a controlled small bulb at the end of it. Water can interfere, so if you have a lot of water, it won't cauterize the bulb. So I'm using a Q-tip. My technician is using the Q-tip to dry, and then I was able to get the bulb. Use some forceps to push the haptic into the sclera, and you want to embed it pretty deeply. By doing it that way, you won't have a bulb sticking above the level of the conjunctiva and sclera. Using the McPherson's to disengage the hooks now, you just grab the proximal side with the hook with one hand, pull the stopper back with the other hand, and then you see I'm trying to save the hook, and so you're doing this kind of 90-degree turning of the hook, and you're able to pull the hook out nicely here. So again, grab proximal, pull the stopper back, disengage it from the pupil edge, rotate the hook 90 degrees, And then when you do it that way, you're able to take the hook out without damaging the tip. And this just allows you to reuse it with more uses. Do the same thing each side, retract the stopper, disengage from the pupil edge. As you pull it out, rotate the hook 90 degrees, and it comes out without damaging the tip. So good, so I'm injecting some more intracameral Kenalog, and you can see there's no obvious vitreous. Going through a limbal incision, making sure, kind of sweeping around, doing the vitrectomy. There's no obvious vitreous in the anterior chamber. Go back through the pars plana, through the trocar, and doing some more anterior vitrectomy. What's interesting is I'm doing this, you can see the pupils getting bigger, and that just kind of tells you and illustrates the whole pupillary block phenomenon. And so this is the vitrector-assisted PI. This is the left eye, and so I'm placing the vitrector through a superior incision and making a temporal PI. And this is interesting. As soon as I made the PI, there's quite a bit of hemorrhage. And so this doesn't happen that often, but it can happen. You can do a laser PI before or after the surgery. Go ahead and grab the trocar with forceps, and as I pull out, I massage the sclera. You want to activate infusion. And when you do that, you know you have a self-sealing incision if you don't see any conjunctival ballooning. And so infusion is activated, nice firm eye, and you see there's no ballooning of the conjunctiva. Pull the AC maintainer out, and then I'll hydrate my incision. So you can see there's a nice small pupil. This patient had a dislocated lens. So you saw my modified Yamani technique. I always like to externalize the leading haptic. This helps access to the trailing haptic much more easy. And by using the 25 gauge needle externalization technique, it's a non-grabbing technique. Before, I would have to grab the leading haptic by the tip with microforceps. And if you're using PMMA haptic lenses, it can damage the tip. And so with this one, it's a CC Lucia. It doesn't really matter. You can really manhandle those haptics and it's still okay. But you saw the technique is a 25 gauge externalization technique. I'm able to dock the haptic on the bevel of the needle, and as the lens is delivered, the leading haptic is docked on that 25 gauge needle. As it's advanced, it's flattened out. You can turn that needle slightly counterclockwise and tilt it so that it kind of helps the contour of the haptic ride up the bevel of the needle, and then you can gently guide it out and it'll be externalized. And then you go after the trailing haptic next. Again, I like to make my needles on the right side and then left side, both facing the approach of the haptic. The right side bevel is facing towards me. The left side bevel is facing away from me. This is the issue. When other people, when you see them doing the Yamane technique, they're using the C2 Lucia lens. And when you see them very carefully, they actually grasp the haptic and they kind of rotate it and kind of twist it so that it faces the haptic the way they want to. And there's nothing wrong with that because the C2 Lucia is very forgiving. And if you do that, it's still okay. It doesn't break or damage it. But you can't do that technique with PMMA haptic lenses. And I do worry that even though you don't break the haptic when you're using the C2 Lucia, you can't change and deform it. So it's not quite the same contour. It might be a little bit tilted. And I think that can contribute to poor lens position. So you do the technique right and everything's executed correctly, but the patient ends up with some type of issue, the lens is tilted or a poor refractive result. And you're kind of like, what's happening? Well, I think it's because when you're doing the C2 Lucia and you're really manipulating the haptics quite a bit, I think that does affect the lens position. And so if you can find a gentler technique, like the one I'm doing with my trailing haptic first technique, you find yourself not really having to manhandle the haptics. And again, with C2 Lucia, it's not an issue, but I feel very confident that I can do this technique even on other lenses with much more delicate haptics. And as a result, I feel like this is, in my opinion, the best way, especially for the learning surgeon, the best way to flatten the learning curve so you know how to do this surgery, even in the context of lenses with PMMA haptics. So I hope this was helpful to you, and I thank you for your attention.